All right, I think we're all ready to get started. Welcome again to everyone. My name is Ben DeVos, Marketing Associate here at Unbound Medicine. Welcome to today's webinar, where Dr. Kate Dzintars will discuss new updates and recommendations regarding COVID-19 vaccines. This webinar will equip you with the latest guidelines on the 2024-2025 seasonal COVID vaccines and provide crucial insights into both availability and administration. Before we get started, I just want to thank you all again for attending today. I know your time is extremely valuable, and we're just very grateful that you chose to spend it with us. Now let me introduce our speaker. Dr. Kate Dzintars is the Associate Pharmacist Director of the Antimicrobial Stewardship Program at the Johns Hopkins Hospital and a practicing clinical pharmacy specialist in infectious diseases. Dr. Dzintars is also a key contributor to the Johns Hopkins Pocket Guides, where she shares her expertise in infectious disease and antimicrobial therapy. Dr. Dzintars will be answering questions live following the presentation. So to ask a question, we ask that you please type it in the chat or Q&A box at any time. Dr. Dzintars, thank you again so much for taking the time to share this important presentation with us. I know we're all really eager to hear and learn from your expertise, so I'll turn it over to you.
Thanks, Ben. Thanks, everybody, for joining us today. Welcome to this, what I think is a brief but fairly important update on COVID-19 vaccination. CDC and ACIP has just released guidelines at the end of August, and so we've been putting them together and waiting on vaccine availability, and there are some important points for you all to be updated with and to take home with you today. And so some of the things that we're going to cover, we will discuss the current status of COVID-19 disease in the United States, compare the now 3 available COVID-19 vaccines, and then we'll take a moment or two to identify some special populations who may be at risk for sequelae of COVID-19 disease, who you may consider for priority vaccine administration in your practice. And so I think that, we can use the classic how it started, how it's going phenomenon with the COVID pandemic. It's hard to believe that it's now close to 5 years since a cluster of patients in the Hubei province of Wuhan, China, exhibited atypical pneumonia-like symptoms. And then really everything started to cascade in 2020 when the World Health Organization began using the term the 2019 novel coronavirus to refer to the outbreak. The first confirmed cases occurred in the United States. And it was very quick that the World Health Organization declared this an outbreak of public health emergency of international concern, followed very quickly by COVID-19 becoming a pandemic. In March of 2020, the US declared a nationwide emergency, and that's really when things in this country started to shut down. But it was all within that same year that the FDA issued the initial EUAs for the Pfizer BioNTech COVID-19 vaccination. And so fortunately, we mobilized very quickly, but it's hard to forget, for those of us that practice clinically, some of these scenes that we just encountered 4 to 5 years ago with overcrowded hospitals, drive-up testing sites, these daily maps looking at the total cases that have rocked the United States with the increasing number of deaths, and then everything that we learned about always ongoing need for universal precautions with hand washing, but the need for wearing a face mask and the concept of social distancing. So how's it going? Well, it's easy to know that a lot has changed over the last 5 years. We've gone through multiple waves and multiple SARS-CoV-2 variants. We had a run on monoclonal antibody therapy, with those monoclonal antibodies being developed and redeveloped to match these ever-changing variants. We were fortunate enough to have a number of antivirals that were approved either through emergency use authorization or now through the FDA. Both remdesivir and Paxlovid are available through the FDA. Molnupiravir still remains on emergency use authorization. We've had more vaccines. Some have come and some have gone. The Pfizer and Moderna products still remain two of the workhorses. We've said goodbye to Janssen, but we now have a new available vaccine from Novavax. Unfortunately, the World Health Organization declared an end to the global health emergency in May of 2023. And so it's been a little over a year since the pandemic has quote unquote officially ended. And while a lot of people really want to make this return to pre-pandemic life, I'm not quite so sure that we can say that everything is all sunshine and rainbows just yet. Because COVID-19 truly remains a public health concern. We're about to see a spike in the increase in the number of cases as we move into what we call the respiratory season. Peak hospitalizations for this particular virus occur through December and February annually. That has been the trend over the last 2 to 3 years, although they really do linger throughout the year. The last several years, we've had what we call the summer surge, and 2024 has been no different, with cases peaking in the 3rd week of August and then falling throughout the first 2 weeks of September. Hospitalizations for COVID-19 disease still remain quite high. Those most often affected are individuals over the age of 75 years or those less than 6 months of age. And that's where we really start to run into issues just with vaccination in general, right? Less than 6 months of age are unable to be vaccinated yet. And we know that there's issues with building immunity as we get into the advanced decades of life. COVID-19 is also associated with more pediatric hospitalizations and/or death than other vaccine preventable diseases. And so things that affect us, such as influenza and RSV, COVID is still taking pediatric patients out at a higher rate than those types of viruses. Half of the children hospitalized in the US in the 2023-2024 season had no underlying medical conditions. And of these children who were hospitalized, 1 in 5 required ICU admission at some point during their hospital stay. Unfortunately, at this time, racial and ethnic disparities still continue to exist with COVID-19 disease. And so we have started to stem our scientific basis on vaccine effectiveness on the previous year. And so I think it's important to take a look at what happened in 23-24 as we start to look forward, not look forward to, but look towards the 24-25 season. And so for last COVID season, there was increased protection against both symptomatic infection, as well as COVID-19 associated ED and urgent care visits, as well as hospitalizations. And so similar to influenza, we're seeing the most durable protection against those who are critically ill. And fortunately, effectiveness of the vaccination was similar across all age groups. So we're seeing that benefit in the very young as well as the very old. Due to changing variants, waning patterns are likely. I think we're on a very short curve to learning that, or just maybe starting to understand, may perhaps be the better way to look at this, is that this is going to become, an annual thing similar to influenza. We are likely going to need COVID vaccination in booster form on an annual basis. Last year's vaccine did particularly well against the JN1 variant. Now we're moving into a predominant XEC variant, part of the FLIRT system that has predominated over the summer. And COVID-19 vaccinations continue to have a very favorable safety profile based on now robust 3-year surveillance. And so the more data we get, the more that we're seeing that these vaccines truly are of benefit. And so for the 2024-2025 season, we have 3 available vaccines. 2 of those are the mRNA vaccines that have been available really since the end of 2020, with Pfizer's first becoming available. The Pfizer BioNTech vaccine, Comirnaty, is FDA approved for all individuals 12 years of age and older, and still operates under the emergency use authorization for individuals who are 6 months to 11 years. On the other hand, Spikevax, also FDA approved for individuals 12 years of age and older, and EUA for 6 months through 11 years. The new vaccine to come into consideration is the Novavax COVID-19 vaccine, which is an adjuvanted protein subunit vaccine, still under EUA only, and just in individuals 12 years of age and older. So the mRNA vaccines are available for our youngest patients, whereas the Novavax vaccine is just those adolescents and older. These vaccines target, again, the JN1 lineage of the Omicron variant. Just want to take a brief moment to go into a little bit about how these two vaccinations work, because really for this particular virus, we're looking at novel mechanisms of action. While mRNA vaccines, these are some of the first licensed vaccines, they have been in development for quite some time, looking at their activity against various oncologic genes. And then we found success early in the pandemic when the first Pfizer vaccine was approved using this technology. And so coronaviruses are named for their crown-like spikes on their outer surface, otherwise known as the spike proteins. And so you can see in step 1 of the pathway here, mRNA that codes for the spike protein is altered and injected into lipid nanoparticles. And this messenger RNA teaches the body how to make these proteins. These copies of the spike proteins are then made, so when individuals are exposed to coronavirus, the body is equipped to make antibodies and fight off the disease. Protein subunit vaccines are manufactured in a slightly different way. This is also a semi-novel mechanism, right? We don't necessarily have either of these types of vaccines available for the other respiratory viruses that circulate throughout what we call the respiratory season. And so the Novavax vaccine that just came under EUA in August of this year is a protein subunit vaccine, which is produced in media, certain cells that include a recombinant virus, where COVID DNA enters these cells, spike proteins are produced, and then they're actually extracted, mimicked, and put into the final vaccine with the adjuvant or the protein attached to it to stimulate the immune response and offer protection from the coronavirus. So the vaccine schedule is fortunately getting much more simple than previously. Anyone who remembers early in the pandemic, we needed multiple vaccines in order to stimulate an immune response. That is getting increasingly simplified as we move forward in dealing with this virus. And so for the 2024-25 COVID vaccination schedule, for any individuals over the age of 5 years who are not moderately or severely immunocompromised, and by previous COVID vaccination history, if they were previously unvaccinated, never having received any of the vaccines before, there's still only a single dose of both the Moderna and Pfizer products indicated, with 2 doses required for the Novavax in those aged 12 years and older only. The second dose should happen 3 to 8 weeks after the first dose. Anyone who has previously received at least a single dose of the COVID-19 vaccination would need only 1 of any of the 3 available agents. And so that would include the products from Moderna, Pfizer, or Novavax, with each of those occurring a minimum of 8 weeks after that initial dose. For our youngest patients, those who are 6 months through 4 years of age, again, not moderately or severely immunocompromised and by previous COVID vaccination history. If they're unvaccinated, the Moderna product requires 2 doses, the Pfizer product requires 3. The column on the far right will offer you the interval that is recommended between each of the vaccination events. If they've previously received the Moderna vaccine, we still operate as we did early in the pandemic. It is recommended that the vaccine, the product that you start with, is the one that you should continue with. So anyone previously who received a Moderna vaccine, any single dose, just needs their second dose 4 to 8 weeks after their first vaccination. If they've previously received 2 or more Moderna doses, a single dose is indicated at least 8 weeks after that second vaccination. And then in this last row here for you, if they were previously vaccinated with Pfizer to start with and received just a single dose, they will need 2 doses of the 2024-25 vaccination, 3 to 8 weeks between dose 1 and 2, and then an additional 8 weeks after the second dose. And then just a single dose if they've received 2 or at least 3 doses with varying intervals between each of those. Looking at vaccination in our special populations, there's really no contraindications to vaccination against COVID-19 disease. The ACIP has been pretty strong in their comments that COVID vaccination is for everyone. So even those with moderate to severe immune compromise, those 6 months of age and older, should still receive the 2024-2025 COVID vaccination. Women who are pregnant, are considering to become pregnant, or those that are breastfeeding should also receive any of the formulations of the COVID-19 vaccination. Vaccination is safe and effective during pregnancy. It has not been associated in any way, shape, or form with fertility problems, and there's no contraindications to receiving vaccination while breastfeeding. Individuals who've had recent COVID-19 disease can use either word here, delay vaccination for approximately 3 months after illness. The one consideration would be perhaps shortening that interval for individuals who are at risk for severe disease, or those who have very close contact, ill family members within their household. Minimal considerations in special populations, and again, ACIP, CDC suggesting vaccination for everyone. And so some big news as I was prepping this talk then just last week, the CDC updated the COVID-19 vaccination recommendations that now actually include a second dose of the COVID-19 2024-25 vaccination 6 months after the first dose in individuals who are either 65 years of age or older, or individuals who are immunocompromised. And so individuals being vaccinated within the month of October would need a second dose beginning sometime in April. Again, I think we need, while I appreciate this recommendation, I also think we need to look for shifting variants and ensure that vaccine coverage is still adequate, and look to see when the next round of updated vaccinations are coming. But for the time being, right now, the recommendation, just as of last week on October 23rd, is the second vaccination should be given 6 months after the first vaccination to those who are over the age of 65 and individuals who are immune compromised. One of the things that really we need to take into consideration when we talk about mass vaccination for all candidates is how these vaccines are supplied and what the storage and handling requirements are. This is something that has drastically improved over the last 4 years that vaccines have become available. Really, all 3 vaccines for those Pfizer in those indicated over 12 years, and both the Moderna and Novavax are all available in a convenient pre-filled syringe. They all require refrigerator storage, but they don't necessarily require additional special handling. Where we still have issue is with the pediatric doses of the Pfizer BioNTech product. Vials are available for those aged 5 to 11 years. It is a single dose vial for pediatric patients. And then the very young, 6 months to 4 years, where the dose is even smaller, they're available in a multi-dose vial that contains 3 doses of each. The issue is that these particular vials require ultra-cold storage until expiration. Once they're removed from the ultra-cold storage, they're okay for 10 weeks at refrigerator. But if they're diluted to the actual pediatric dose, they must be used within 12 hours of dilution. And so for certain primary care clinics, this can present challenges. Do they have the appropriate areas to store these types of vials? And so this leads me to kind of bring some of these points home and where we still see remaining barriers to COVID vaccination. And really the biggest one right now is that we have too many respiratory viruses. We're getting into some complex routine vaccination schedules that now includes COVID-19, influenza, and fortunately, the other virus that has really come into play over the last 3 to 5 years, respiratory syncytial virus, or RSV. And again, in that arena, we've actually also had several vaccine updates, and most recently, Abrysvo was now indicated for individuals between the ages of 18 and I believe it's 60 years of age, who are at risk for lower respiratory tract disease. And so initially that vaccination was for those over the age of 65. Now we have improved those recommendations to cover more patients. The storage space considerations that I mentioned on the previous slide certainly increased need for provider education, again, due to the complex routine vaccination schedule of multiple respiratory viruses now. But all of this combined together, unfortunately, sets us up for the opportunity to have more vaccination administration errors. Certainly, there's a financial burden to various healthcare practices, costly vaccine and low demand. I'll show data on the next two slides, suggesting a little bit of a lack of confidence with some of the data that's available and vaccine trust. And then lastly, patient access. There are fewer primary practices that are able to carry this many products just because either of the storage availability, the finances involved up front, and then the concern for expiration for a vaccination that is unused. And so it's unfortunate that over the last 3 to 5 years, more and more Americans are becoming less concerned with COVID-19 disease. Now it is down to just 1 in 5. It was previously 2 in 5 18 months ago, who consider COVID-19 to still be a major threat to the US population. This virus is still significantly circulating. It is still the leading respiratory virus cause of hospitalizations compared to influenza and RSV. And so we're still at a point that it should not be taken lightly, but the evidence is fairly clear that most Americans are kind of over COVID-19, we can say. And then finally, to coincide with this, there's a declining share of Americans who desire or actually do have the most up-to-date level of protection against COVID-19 disease, with just under 30% of US adults who are reporting that they're up to date with COVID vaccination. And so certainly for our primary care practices, education is key to have people come in, have routine vaccination against COVID-19, influenza, RSV, and the other circulating viruses. And so just to briefly wrap things up here, COVID-19 is certainly still a relevant public health concern. We're fortunate to have 3 products available for the 2024-25 season, and vaccination is recommended for most, if not all, people aged 6 months and older. And improvements have been made to our vaccination process in terms of just needing a single dose up front, the availability of pre-filled syringes, et cetera, but certainly more work remains to be done in this arena to continue to promote resources to the general public and have them trust this vaccine process again. And so just to finish up, we will include this QR code with a link to the Hopkins antibiotic guide. I will turn it back over to Ben, who will be able to comment on this a little bit further than I will, and we'll look forward to joining you all for questions in just a moment or two. Thank you.
That was wonderful. Thank you so much, Dr. Dzintars. As you said, for those interested in exploring more expert content, like what Dr. Dzintars presented today, we're offering a 14-day free trial of the Johns Hopkins Antibiotic Guide. You can sign up for the trial by scanning the QR code on your screen or by visiting our website. So Dr. Dzintars, thank you again for that fantastic presentation. This was very informative, and hopefully others found a lot of value in it as well. Thank you again to everyone for tuning in today. We do have some time for some questions, and as a reminder, you can put those in the Q&A box or the chat. We do have a few questions to get us started. So Dr. Dzintars, to start, will there be any combination vaccines available such as COVID with influenza?
I think those are coming. My understanding or brief review of the literature is that there was a Pfizer product investigating combination vaccination with against coronavirus and influenza, and it met the endpoints for COVID-19 as well as influenza A, but it did not meet the endpoints for influenza B. And so I think that they're going to continue to work on that. And hopefully, and I have 13-year-old twins and an 11-year-old who vaccination is not fun for them. And it will be so much nicer to be able to say, hey, you only have to get one shot in the arm instead of two, when I make them go for their vaccinations every year. But I think that those are coming, and I think that that will be a big boost to the general public, you know, to kind of ease the number of injections that will be needed.
That's fantastic. The next question we have is, we know that chronically ill and older people can benefit from the COVID vaccine. What is the reason that the CDC recommends the COVID vaccine for healthy children?
So this is what I was semi-alluding to from ACIP. There is very little risk to vaccination in general, and certainly a protective effect, regardless of immune status for any of the pediatric patients. And so the approach to COVID-19 vaccination is very similar to how they approach influenza. Everybody should get their flu shot. Everybody should get their COVID shot. You know, they did back it up with data. 50% of the children who were hospitalized in the last virus season in 2023 and 2024 were well children. They were not kiddos who were immune compromised in any way, shape, or form. But half of those requiring hospitalization were healthy kids, and 1 in 5 of those kids ended up in an ICU. And so vaccination is certainly important. And I would recommend it. I support the ACIP's recommendations in suggesting it for everyone.
Excellent. The next question is, does one of the vaccines currently available target the current XCC variant better than others?
No, they are all the same. All 3 vaccines will target the circulating variants in the same manner.
Excellent. And I think we have time for one more question. Do you expect other groups will need to have a second dose of the COVID vaccine in addition to those over 65 years or immunosuppressed people?
That is very hard to say. I am uncertain of that at this time. I was surprised. I thought that ACIP's recommendation perhaps was a little late, suggesting that another vaccination was due 6 months after the first one. That would put most people getting vaccinated late August, April, May, which is not necessarily the respiratory season or the end of the respiratory season. If the variants circulating at that time are still the same that we're seeing now, where we're worried about the quote unquote summer surge, then yes, I suspect that there will be modifications made, and for otherwise healthy individuals not meeting that over 65 or immune compromised, that perhaps it'll be on a case-by-case basis. I could see them making the recommendation to say, for otherwise healthy individuals, talk one-on-one with your primary care provider and make the decision that's best for you.
Thank you so much. Well, this has been wonderful. And once more, I want to thank you, Dr. Dzintars, for your excellent presentation. And I hope that everyone found this information to be valuable for the future. A video of the presentation will be provided to all attendees and those who signed up for the webinar. So please be on the lookout for that in the coming week. At the end of this session, we'll be distributing a survey. Your feedback is very important to us. We would greatly appreciate it if you could take a moment to fill that out. It will be really helpful for us to provide more webinars from Unbound Medicine and Johns Hopkins Medicine. In addition to Dr. Dzintars, I want to thank everyone for attending today. If there are any questions about this webinar or future webinars from Unbound, please contact us at webinars@unboundmedicine.com. Once again, thank you, Dr. Dzintars, and I hope everyone has a great afternoon.